Well, with your permission, we'll go ahead and get started this evening. I want to welcome all of you to our 11:15 waiver project update. Thank you all for being here this evening, and Mr. Garcia, thank you for sitting in for a little while and very busy. It's always nice to have you part of this as well. And we've been actively busy. Many of you who are not in the Parkland system, but from other systems, probably also extremely busy with the 11:15 waiver process. It is evolving, it is maturing. We're all learning new things about our role, and specifically Parkland and our role as the RHP, the Region 9 anchor. So we'll be talking about that a little bit this evening. From Parkland, we have Ted Shaw with us. Ted's going to do a substantial amount of presentation, and also from Dallas Medical Resource, Margaret Jordan, who's been part of the 11:15 waiver maybe since before it was even thought of. So Margaret's got a lot of history, and we're very glad that she's part of the network as well. So Ted, I'm going to turn it over to you.
Thank you. We'd like to tonight, first of all, anybody that hasn't signed in, if there's a table out in the lobby there, if you wouldn't mind signing in. And particularly if you would like to make public comment later, let us know. Either Catherine, who's in the back there, or I believe that's probably Lisa, who's back this to us, out in the lobby. But thank you. Before I begin the presentation, she slipped out. Where is Jody? Oh, there she is. I want to acknowledge Jody Springer, who has served as basically the anchor for Region 9 for the last 17 months or so. And Jody is basically the heart of everything that's happened here at the 11:15 waiver. She's been a wonderful person to work with, and as I'm sure all of you that are participating providers recognize that without Jody's leadership, encouragement, energy, and knowledge, we probably wouldn't even be where we are today. The reason I say all that is next Thursday is Jody's retirement day, and she's leaving us and moving on to better things. So I want to thank you again publicly, Jody. You've been wonderful to work with. Thank you. And to fill those rather large shoes, in the diminutive size maybe, the large shoes is Christina Mintner. Christina has joined us to serve in that anchor role. She's been with her all of now it's fourth day. She's worked with the 11:15 waiver in Houston, so she knows things like what is an IGT and 11:15 waiver and what is a district project. So again, welcome Christina, and now you can send all your questions to Christina. So I'll see if I can make this work. There we go. Aim at the right thing. So basically, Bob and I are going to do the introductions, and then I'm going to move into the 11:15 waiver overview. It doesn't look like we have too many, if any, public members here, but I'll try to capture where we have come. As you all remember, we began this journey well over a year ago. In December of 2011, we received CMS approval for the 11:15 waiver. I would say almost a year later, we began the process of trying to gather everything. The 11:15 waiver is a replacement and an opportunity to replace the old UPL program in the state of Texas, as well as to leverage more dollars out of the federal government to transform healthcare. And so the 11:15 waiver is basically a two-part program. One, which is and get that in a second. One, which is the UC dollars, or uncompensated care dollars. That is to help hospitals that provide care to and other participating provide care to in an uncompensated fashion, and incur those costs or try to recoup those costs through the UC dollars. And then the second part is what all of us are in the middle of and working very hard on, which is called the 11:15 waiver, transformation projects or district, and we've come to know them. First of all, the 1115 waiver was designed as a regional program across the state. There are 20 regions. We are in Region 9. Region 9 consists of Dallas, Denton, and Kaufman counties. And each RSP has an anchor, and we are the anchor. Parkland serves as the anchor for Region 9. The other parts and players in this are the hospitals, community mental health centers, local health departments, academic science centers, physician practices, and some other community stakeholders, all of which participate in one form or another in the 1115 waiver. As I said before, it's broken into two components, one which is the uncompensated care piece and one which is district. We're going to talk about how we got to it and how those things get kind of split up as we go through this. This is a slide that sort of said this is where we were supposed to be. And when we began this project, we felt like there was D1, which is kind of the planning and development piece, and that was fiscal year ending basically 2 years ago. And that didn't quite get done. So the plans were then supposed to be submitted and developed by the end of fiscal year, almost calendar year 12. And then by this time, we were supposed to be fully implemented, all of the plans approved, and we'd be well on the way of implementing all those project and plans. As you can see from this slide, you'll see, well, it didn't happen quite like that. We're now a little over 2 years into the program. Some parts are approved, some parts are not, and there's some to still come. And we'll talk about, we actually submitted our plan last December for the region. That was then reviewed. We've gotten partial approval on some of the things that came in early May or late May. And then we've got, then they divided it into not just, as you know, the district is categories of 1, 2, 3, and 4. Then they decided to add to the categories the phases 1, 2, 3, 4, and 5. Is there a phase 6 too, phase 5? Which is basically where they took the program as we submitted it, and as we'll go and look at some of the pieces parts, they have approved some, deferred some, going to give us approval on some parts later, and we'll see how, and we'll talk through some of that. So as the original submission, we submitted 120 projects for 25 performing providers. And this is where we stand at this point. We have had, the plan was submitted to, again, you can see, CMS did an initial review, got us some feedback in May. And then where we are today is that some of the projects have been approved. All of the values for those projects that relate to DY4 and 5 are still on the table and to be approved. And we still have another couple, at least, of significant processes to go for, which we'll talk about tonight, including finishing the filing for DY2, doing the submissions of what now are determined to be the 3-year projects. And we'll talk about that as we go forward. Since I can't read that, I can flip. When we originally submitted the plan, as you were again recall, if you're familiar with DY or with the process, there are 4 categories. Categories 1 and 2 are basically what the projects are, how you can implement them, and what you expect to do. Projects 3 and categories 3 and 4, how you get measured. And when you look at what those values mean to where we are today, the district portion of this means that Region 9, this is just Region 9, is 1 $1.5 billion over that 5-year period. The DY1 has come and gone. Those $771 million were distributed last year, last fiscal year in there. And then DY2 is where we are at this point in trying to, although we finished the year, and the year was ended September 30th, we're right now in the process of filing and hopefully be getting paid on some of those projects that we began last year. There was a filing that happened in August for many of us. Those were the first projects, and for example, Parkland submitted 6 of our projects for review and approval. But all of the projects have to be submitted for approval as to whether or not we met your DY2 milestones and metrics by the end of October. So we have a big meeting and a big date coming up next week. So you see though that the total, if you look at what's happened, is $1.5 billion. If you focus on the total for just DY2 and 3, which is the only today the only approved dollar values, you see that there's a potential of $630 million in value to be created over the 2 years. So when we got the approval letters back in May and they decided to divide everything up into phases, you'll see that initially in May we only came back with what then looked like about $414 million in projects for DY2 and 3. There were a lot of, there was phase, I think exactly 2 instead of phase 1, but phase 2 we went through and got some additional information, further review, and so in September, in September, we got a little bit further clarification, and now at this point we've got $547 million worth of value that's available for DY2 and 3 to be earned, subject to meeting metrics and milestones, and some of which is still to get further approved. We'll talk about that in a second. You'll also note in DY4 through 5, no numbers. That's because nothing's been approved for DY4 and 5. The challenge with that is those of us that are participating providers are executing on these projects right now, investing money, building infrastructure and things to deliver it. And our anticipation is that those values will be approved and we'll reap those results in DY4 and 5. A summary of where we are as of October. Again, 25 performing providers. There were 114 projects initially approved. Out of the 120 plus projects that were submitted, 5 were withdrawn, and 1 is still pending process. That one which takes a while. So there is a handout that looks like this. It's available on the desk outside. We pick up one on the way in. And it has a listing of all of those projects. Probably the principal reason, other than giving you a status of where we are for being here tonight, is to kind of talk about where we are with these new 3-year projects. 3-year projects were an opportunity that after CMS had gone through approval and review of the project values, had we used up all of the dollars that were available to us. If there were any additional dollars available to us, we were able to submit what's called 3-year projects now to take up that value. If you recall from our previous public hearing when we announced, we held back at that time about $80 million of funding for anticipated projects that relate to behavioral health. Region 9 is particularly different than the rest of the state in that our region is funded, our behavioral health component in this part of the state is funded differently. And therefore there weren't easily available statutory funds for IGT related to behavioral health, and so we've been working through that. And as you'll see as we go through, a significant piece of the now approved, or not approved, about to be submitted, 3-year projects from the behavioral health area. The process we went through, those of you that participated, is that we asked everybody that wanted to submit projects for the 3-year project. One of the requirements was that for it to be finally approved, you have to find an IGT provider. That's an intergovernmental transfer. Parkland has extended, they agreed to take up as much as it could under its original commitment. But then we looked and looked around and saw if there were others that could pick up that. And as you'll see from the following slides, I want to thank MetroCare. Ms. John, I want to see Dr. Bruce. But I wanted to thank him because a lot of us will see there's a significant amount of dollars that are being funded through MetroCare. That's going to make some of the behavioral health projects become a reality that we're hoping to do. So then all of those projects that were submitted were sent out to every participating provider, and each participating provider hospital got a vote so that they ranked them. So we ranked all of the projects based on the criteria of whether or not they were the right thing to do for the region. And then Jody and the team accumulated those results, and you'll see how those rankings came out in just a minute if you haven't already gone to the website. The next 3 pages talk about those projects, and they're again listed as part of your handout that are available to you. What I would like to point out is if you look at the project title, you find also where is the kind of get its money, if you will, where is the funding from, and I'll go through that. We've got Dallas NHMR that's again going to be a MetroCare, has stepped at a time with their IGT Parkland. This is a opportunity for us where we're going to fund an additional district project. Texas A&M is funding its own, UT Southwestern is funding its own. Dallas Children's, I believe, got MetroCare to back them up and fund that project. A couple more here from Parkland, UT, and MetroCare. You'll see, so those are the other forms of IGT. One of the things about the waivers are a few closed loop scenarios. Closed loop being that they could fund for themselves. UT Southwestern is probably the largest in our area that's able to do that. Baylor College of Dentistry was one, etc. But that so UT, which have withdrawn several projects, submitted several new ones they're going to fund. One new participating provider here that was not on the original list in the past is Timberlawn, through an arrangement with MetroCare providing IGT for them. Another provider behavioral health project that we're able to extend to. Trying to get last year, and you'll continue to see the rankings. Another new provider that entered the market is a long-standing provider of wonderful care here in North Texas, which is Texas Scottish Rite Hospital. Many of you are familiar with them, that they never billed for anything, charge anything to care of their dynamics of about a year ago. They now have a Medicaid license, and so they become an eligible participating provider. Parkland will be providing some IGT for their projects. So as we look out for the 3-year value, we think we have a little over $200 million available for all 22 projects. If we were to implement all of them, we would be at $242 million. When we get the final CMS valuations on the DY4 and 5 values, we expect that will not be as high as we submitted it for all of it. And so there will be more than just the $200 million available. And we're going to attempt to fill that up in terms of trying to take advantage of what we can. But if we don't take advantage of it for Region 9, then those dollars that are available return to the state, and the state has an opportunity to either use their own IGT to do some project, or return it to the other regions in the state. So again, you've got the prioritized list in the handout. The comments are obviously always welcome. Submitted now, not to Jody, but to Christina. If you'll see the website there is our website, for the program. So if you go to that particular URL, or if you go to Parkland's external website, you can navigate to get to 1115. Now, finishing kind of the presentation tonight, I mean, that's kind of where we stand. We're right in the need of filing for DY2 characters, getting some monies in return. UC dollars and IGT dollars are in the process of being finalized at the state so that we can draw down some more of those dollars. But there's a lot that still remains uncertain. And what I mean by that is we don't know what any of the DY4 and 5 values are. Those are to come theoretically in the October timeframe. Oops. We're already past the October timeframe. And with the shutdown in Washington, CMS had to suspend some of the work. So we'll see that in November, December timeframe. And my experience would say maybe beyond that. But, we'll hopefully get that done. The other one will be the submission, and we'll be submitting these 22 projects plus all of the ones that didn't have IGT to HHSC next week, 31st. Or is it get an extension on it? It's either next Friday or we'll be submitting those. And then HHSC always has the opportunity to approve them or disapprove them if we don't. There may be other opportunities. But once that list is done, and once it's complete, I don't know of any way we can add any more projects. The last shot we'll give it a major part of all of this, and Margaret's going to discuss, is what do we learn from all of these efforts? Each of us doing various projects, and how do we coordinate that? How do we take those learnings and actually truly transform healthcare? So there should be some learnings in here, and I'll turn it to Margaret. I'll do it. Tell me what.
Well, first place, good evening. How's everybody this evening? We're glad you're here. I think an exciting part of this plan is that we had to submit a learning collaborative plan that is required by HHSC for each prior meeting to submit September 30. But the purpose of the plan really is so that we can share our learnings on these projects as we go forward. Two types of sharing. One is to share among the performing providers who have similar projects so that they can get their best practices together, so that they can improve each of their projects, so that we'll have strong projects with strong performance that really does or do transform some aspect of care. The second very important part is that as a whole, the region will want to be able to demonstrate that we've achieved some of the outcomes that we're trying to achieve in terms of transformation of care in this region. So in order to do that, this plan actually conceptualizes, can we go to the first slide, please? 4 areas or at least 3 principal areas of elements. The first has to do with the region-wide experience and learning that I mentioned. That's for the overall plan, so that there will be a entity headed up by Christina over here, or a committee that will constantly look at where we're going in terms of the local region, the overall regional plan, and whether we're implementing. So I won't get into the process, but there will be people doing that on a periodic basis. The more important one, I think, for a lot of performing providers is the shared implementation learning. where you get providers who have similar projects together to look at what they're doing in terms of developing those projects and the operation of those projects. So, for example, we have a number of our providers doing chronic care management. So it's conceivable that those who are doing chronic care management will get together and talk about what they're doing on a periodic basis to see how they can each improve their project related to that. Or patient navigation systems are another one that a number of our performing providers have got projects dealing with that. When you come to the improvement collaboratives, that's more of us really looking at whether or not we impact the outcomes that we say we're going to impact in these projects. Some of the outcomes have to do with readmission rates, reducing those, improving certain aspects of diabetic care, preventing complications of different types. So in order to look to see if we're really doing those things, and by the way, all of the projects that get paid, as Ted has mentioned, have milestones related to a number of these things, and they will be submitting those to HHSC and then on to CMS so that they get paid. Well, obviously, we want to make certain that you're able to get the full amount, that your milestones are accomplished so that you get the money, but more importantly, that the actual care is improved. So this will be an important part of that, the improvement collaboratives. With a 10 to the next slide. This is just a kind of chart so you can see this visually about what we're talking about. The categories 1 and 2 are the intervention projects themselves. The ones, the similar ones I mentioned, chronic care management, some of the patient navigation things, improvements in access to primary care, and you see we will be working to strengthen those implementation projects so that the outcomes are what we hope to have, which is really what everybody wants to see, including CMS, which is why they are looking to this as a transformational demonstration program. And then, obviously, that will strengthen the outcome achievements will go back into strengthening the project. So I want to thank Jody publicly for putting together this plan, and I think most of you should have received it in hard copy. And the challenge will be for Christina to implement it, and I'm certain she is up to that task. And we will be moving right forward on it really soon with that. So, Ted.
Thank you, Laura. I want to again thank Margaret. She is employed at Parkland and doesn't have to do all this stuff. She works with us through DMR, and they've been a huge supporter of this whole process. I want to thank Margaret in particular for she's a real boss.
Well, yeah, Ted, we'll open it up for public comments or questions to the degree that the panel can answer those, or at least we'll take information from you and get the answer for you if we don't have it this evening. So we invite public comment or questions on the plan as far.
We don't have anybody listed.
Okay, Catherine, is there any of the public officials here that I can't see this far?
Well, we have Nicole Flett from Senator Nelson's office.
Thank you for being here, and please express our appreciation to the Senator.
And of course, Ruby, the present Judge Jenkins' office.
So
Commissioner Garcia's staff is here earlier as well.
Commissioner Price and Commissioner Garcia were both here earlier, and I saw the health department here. So.
Okay.
No other questions?
No other questions? Thank you.
All of this is very clear to you, correct?
You can go to the Parkland website, see the information, and we'll continue on in the best interest of our region, of our three county regions. Thank you all for coming.